Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Kyle Wilsey. He's a pediatric critical care physician. Today's Kevin MD article is When Every Second Counts, the Evolving Challenges of Pediatric Transport. Kyle, welcome to the show.
Thank you for having me. I appreciate it.
All right, so briefly tell us about yourself and then the Kevin MD article that you wrote for those who didn't get a chance to read it yet.
Sure. So thanks for having me. My name's Kyle Wilsey. I'm one of the pediatric intensivists over at Cedars-Sinai Medical Center. Been in this role for 5 years now and happy to continue to grow our transport program. Our unit's an interesting mix of kind of both pediatric general critical care and cardiac intensive care. So we get a whole smattering of things in our unit.
All right, so what got you interested in pediatric transport in particular? And then talk about the article.
You know, at one point I kind of just fell into my lap. And then as I delved into the intricacies of bringing an ICU to a patient rather than them coming to us, I was like, this is really interesting. This is really cool. There's a lot of it's those procedures, it's that intensity, it's that unknown that really drew me into the position. So, and on top of that, I'm a big passion person for education and providing that kind of knowledge and bridging the gap between your bedside caretakers and your physicians. So it's really kind of just naturally fallen to something that's really truly passionate about. As far as how I came up with this article, the interesting part about my job and my current role where I'm at is this is a brand new team starting from scratch. And that's a little interesting in the current world of pediatrics and critical care in general. Most of these transport teams that already exist have existed for, at least a decade, if not longer. And we're talking about major, standalone tertiary or quaternary children's hospitals. So this is kind of like we're a diamond in the rough in the middle of several diamonds around us and trying to figure out how to get our footing. So as I've kind of developed our team, it's been the biggest challenge is I have mentors to look to,
Yeah.
but building from nothing. And when you ask those mentors, how did you start your team? I always heard the same thing is, well, what do you mean how I started it? I got handed this role. I don't know how it started. So, having, that's how long these teams have typically been in rotation. So I really had to kind of like set the pace for my team, learn and go as they did it. Not to say that I didn't have mentorship to get there, but that's kind of what drew me and wanted to kind of share my experience with the world and sending out that article.
Sure. So, give us, to get everyone on the same page, what exactly are we talking about when we talk about pediatric transport and some of the challenges that makes it unique in contrast to adult transport?
Yeah. You know, I the mantra within pediatrics has always been these aren't little adults, and,
Yeah.
and it's true to a very very large extent. It's not uncommon for us to get a call from an ER who may only see a tenth of the volume as pediatrics. So, and most of those patients that come into ERs are usually okay to get discharged. But then you have that small subset that needs to be admitted, and then you have that even smaller subset of patients that really need critical care, really need that
Yeah.
that extra uh, TLC to really get them across that gap of being sicker. So you move that mindset to pediatric critical care transport, it's even more specialized. You have to be able to care for that entire age range of 0 to 18 months, and we can even include neonatal transport in here, and all the special diseases that go with it. Not just your standard kind of what you would think in your mind as respiratory care, but you're talking about congenital heart patients that you're transporting and bringing an ICU to, figuring out how to stabilize them. And our adult colleagues may just not have that same amount of experience with those sorts of things. These are specialized things, and having to fine tune the medicines that we give and physiology, quite honestly, is a little bit different for every age range as you kind of go up the ladder of ages. So it really takes a specialized team, and you will find that throughout the country, these are the most highly trained, multi-tooled teams you can send out into the field. They are specialists among specialists, so they can really be ready for any situation that comes to them.
In your article, you talk about a particular case that really piqued your interest into this whole area. So, for those who didn't read your article, tell us about that case that really was life changing for you.
Yeah, it was in my final year of fellowship, and where I trained, the fellows would go out on those, calls where they needed an MD in the field. And I can remember arriving to this very, very small ER, and you know, without getting too far into the weeds, this kid had unfortunately been in a car accident, had pretty severe internal wounds. If you look at trauma data about these sorts of the mechanisms of injury which he suffered, which is being ejected from the car, unfortunately, the survivability is usually pretty low. So anyway, they arrived, and this kid had had multiple invasive trauma-based procedures just to try to resuscitate him. And lo and behold, they did, but resuscitation in pediatric critical care is as good as the endpoint, and we're talking about the long end of the game. And unfortunately, this child ended up succumbing to their injuries, but being there and being in the trenches for literal 12 hours with a hospital anesthesiologist, their trauma surgeon, their ER doc on the phone with my medical command officer trying to get this kid even stable enough to get from one point to the next point was really kind of eye-opening, because that's a highest echelon of critical care that you can really do, other than providing something like ECMO.
One of the things that you talk about in your article is a lack of national standards when it comes to pediatric transport. So tell us the extent of this issue and why that matters.
So yeah, again, as part of my role matriculating into this is making sure my teams remain competent, following hopefully national, NHSTA safety standards and all the other things. And I, lo and behold, found that those don't really exist. They have EMS that sets very, regional based things, and then you kind of go up the chain to regional and national based safety standards, but it really doesn't set the bar for a
Yeah.
pediatric critical care transport team. So the resources of like trying to figure out what my team needs, how to create a training and didactic program, how to set competencies for certain procedures that they can do in the field that RNs and RTs can do is challenging. The AAP does have a very, very detailed manual, and it's a great resource, don't get me wrong. But even they kind of espouse like, hey, there's no national standards to this. We all kind of set the tone amongst each other by communicating with each other, which is really, really probably the best thing that we can do at this point.
Yeah.
But the needs of a pediatric critical care transport team all depend on the system of which you serve. For
Sure.
example, I'm centered in LA. We have multiple critical care pediatric transport teams regionally here, locally, that can go out and serve. And it's a little easier to grab those patients versus a team who might be located in rural Kentucky. They are going to have a much wider encatchment range. They're going to have a wider breadth of skills, and they're going to have farther distances to travel. So all of those things really kind of boil down to you have to train your team to what your hospital is going to be attuned to picking up. And that can be a bit of a moving target, especially as seasons change,
Sure.
respiratory viruses come and go. And that makes training a little bit difficult, but all the more rewarding when you kind of get your stride.
So take us through the logistics of creating a pediatric transport team from scratch. So each major academic medical center that has a pediatric ICU, they have to come up with their own transport team to bring pediatric patients to them, these critically ill patients.
It's not necessarily required. You typically in your standalone freestanding children's hospitals, that's going to be something that you want just to be able to go out and get kids. But, starting from scratch is interesting. You've got to hire the right personnel and go for the hiring process, which is, finding hopefully experienced, dedicated nurses. And these are nurses that are going to be solely fit to the role of transport. And then from there, picking out a respiratory therapist that can also be ready and able to equip to do intubations and taking over airways in the field, which is something that as physicians and intensivists, we're much more used to doing or having fellows do. So I have to really get their skills sharpened, get that tool set attuned to being able to almost think like a physician in a field where they're used to having physician orders to set the bar. So it's really having to try to bridge that autonomy gap in being providing care for kids like this. So I think that's the biggest challenge.
Now, this sounds, of course, like an expensive proposition. So, like, how do you balance some of the financial pressures that hospitals are facing, and you wanting to create, of course, the best team you could assemble?
Yeah, this is a bit of a stickler. This is hard, without getting too far into the political mire that we're in right now. It's difficult because you have to realize who is paying for this, right?
Yeah.
Is it the center that pays for this? Do we eat some of the cost? Inevitably, we will all eat some of the cost. Do we rely solely on charging the healthcare plans or insurance companies that do this sort of thing? So it does become a prospect of being expensive. You've got to actually have the overhead cost of hiring a nurse and RT 24/7. You've got to have a fleet of vehicles. Sometimes people use third-party EMTs so they can just bring them in and out. If you have air transport, those are expensive costs that you have to really kind of weigh in. But, it's also one of those things that is a community need. It's one of those things at some point a hospital has to think, oh man, I know this is expensive, but like you want to help children, you've got to have a team that can go out and grab those children because again, if you don't have a critical care pediatric transport team, it's going to be a third party system that is usually used to taking care of adults, and then that can leave kids vulnerable.
Now that you've had this experience for 5, 6 years now, what have you learned in terms of advice that you could share for other pediatric critical care physicians who may find themselves in similar positions to you and may need to either optimize or start a pediatric transport system from scratch?
Yeah, I would say my one of my mentors that I work very closely with is it's always about scope and scale, right? Scope and scale. You know, we're gonna help whoever. It's just the calling of what we do. We're gonna want to help whoever we can, but you also have to respect the boundaries, not only the realizations of financial implications in medicine. It's expensive to start these teams. It's expensive to maintain these teams. It is a high time burden to also educate and keep competencies up and really flourish these teams. You also have to, on the other end of the spectrum, we haven't talked about this, but most of the time when you deploy one of these teams, it's typically when you look at national mixes of what these teams are comprised of, it's usually an RN and RT. Seldomly you will need an MD, but that's another extra layer of cost, an extra layer of training, an extra layer of comfort that you really have to impose upon your team. So I would say scope and scale. Understand your audience, understand your community, understand what their needs are, and go out and shake hands. Go out and meet them. Go out and meet the ERs and ask them, what do you need? What can I do to help you? How can I help achieve that goal?
And in terms of the foreseeable future for your program, it's relatively young, 5 years or so. What do you see as the continuing challenges of developing your own program?
It's here locally where I live, it's competition.
Okay.
It's a lot of competition, and I don't want to say that medicine should be a competition, but when you're having to be sandwiched between multiple children's facilities and a large urban population, you certainly have a lot of opportunities to go pick up sick children. There's definitely, these are specialized centers, and even while it is a highly populated region, it still doesn't feel like enough beds, enough support, enough resources for children. So it's really kind of going to be a slow growth process. And I figured that's what you want. But you want that reliability. You want your community to be confident in your teams. You want them to be confident and excited when you come to the door and they're like, oh, thank heavens they're here. We can kind of partner together and really help get these kids stabilized and get them to the centers that they want. So slow and steady always wins the race.
We're talking to Kyle Wilsey. He's a pediatric critical care physician. Today's Kevin MD article is When Every Second Counts, the Evolving Challenges of Pediatric Transport. Kyle, let's end with some take-home messages they want to leave with the Kevin MD audience.
Yeah, I would just say kids remain one of the most vulnerable populations that we have the honor to serve in medicine. It's become a passion, and if you ever have a passion for this, really look out to your community and see how you can help. And that's really how I got entrenched in figuring out transport medicine and really starting to become hopefully a leader locally for myself and developing this further. If you ever have interest in it, go to your mentors and say this is something we need and I'm interested in.
Kyle, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Of course. Appreciate it. Thanks so much for the opportunity.